temporally I say I can work inside, I can work. By the way, temporal methods I can use on the endoscopy. It is arterial clamps, forceps. During the surgery, temporally inside of the wound, I can apply these forceps. By the way, samely I can apply the tourniquets inside of the hospital. For example, you make the surgery in the hand region, you apply the tourniquet in the arm region to prevent any bleeding. Again, especially it is used for the extremity. That's it. Don't forget that temporal methods only is pre-hospital. No, in hospital I can use it also. But finally, let's come to the most important methods. Yeah, it is the permanent methods. I have permanent method inside, I have permanent method outside. 100 times I told you, most usual permanent method inside of the wound, it is ligation. Equally, we make ligation with sutures. Then you provided the thread, not only surround of the vessels, but through the neighboring located structures to fix it. By the way, there are important rules for the ligation of the vessels. Remember, please, for ligation of the veins, how you understand that this is venous bleeding? Primary, by pulsation, it is absent, and secondary, by color of the blood, it is dark. For arterial, vice versa, we have pulsational bleeding, and we have bright red color, because it is oxygenated blood. If you see that this is venous bleeding, you know, in venous kind of the bleeding, like you open water in your kitchen, blood just flow without any pulsation. Usually one ligature in the proximal end, one ligature in the distal end, and we strongly tie both these ligatures. For the arteries, as I told you before, situation is another. If it is artery, unfortunately I didn't take the red color, so I will draw by the blue. By the green. This is artery, for example. You see two ends. By the way, in majority of the cases, bleedings will be from proximal. Distal one will not give so much bleeding. Or, in exceptional cases, if there are anastomosis with both ends, as we described in facial region, both ends will give the equal bleeding. Now let's take the first case. Then there are mainly bleeding from proximal end. What are you doing here? You apply two ligatures in the proximal end. Distance between these ligatures approximately 0.5 centimeters. Ligature number one, you tie very loosely just to decrease the diameter. Ligature number two, you tie very strongly to close the lumen. In the distal end, you apply only one ligature and you tie it strongly to close the lumen. Why it is necessary? Inside of the proximal end, there are very high pressure. If you will apply only one ligature, maybe pulsational flow will remove it from the wall of the vessel and will give formation of secondary bleeding. Secondary bleeding happens after some time after the traumatization. For example, after the surgery, after the ligation. So, what I can do to prevent it? I apply two ligatures in the tip. First, I tie loose to decrease this pressure rate. Second, I tie strong to stop it. You can say me, why it's not necessary to apply both strongly? Simply, guys, if both these ligatures I will tie very strong, after several times I will have necros between them, and one ligature will be loose. Again, I will have only one, which is not enough. Idea is understandable for you. As I remember, please, for the big arteries, we use this rule. If it is anastomose artery, same I will do for both ends. Two ligature in proximal, two ligature in distal, because I have equal bleeding. But it doesn't matter, is it proximal or is it distal? Do you understand me? Very well. Let's continue. What else I can do inside of the wound? Diathermical coagulation. You know, I can use electrical some equipment like electrical knife, electrical dissecting forceps to coagulate it. What is coagulation? Denaturation of the proteins. I form the thrombus of the vessels. But remember, please, It can be used only for small diameter vessels, less than 1 millimeter in the diameter. Ask me why. Because if you will make the coagulation of middle or big vessels, of course in time of the surgery you will arrest the bleeding. But of course after pressure will be increased due to the physical activity. And this thrombus will be cleaned from the vascular wall and will give formation of secondary bleedings, which I mentioned several minutes before. Let's say, remember please, it is strongly forbidden to make the coagulation of middle and big diameter, more than 1 millimeter. It's forbidden. Very well, what else I can do? I can use some chemical liquids, for example, hydroxyperoxide. It's also made coagulation, and usually we use it to arrest the capillary bleedings. I can use the hot solutions, hot saline, for example. What the effect? Denaturation. Again, it makes the denaturation of the proteins, and if it is bleeding from small vessels, like the capillaries, it can be used. I can use the special hemostatical sponge. What is it? It is sponge which is prepared from the plasma of the blood, from fibrin. It is glue. You cut the piece of it, you put it in the place of the bleeding, it is resolved, it is gives the thromboticization, it is closed the place of the bleeding, and it is arrest. Again, small bleedings. By the way, very useful method to arrest the bleeding from brain vessels. You understand that root manipulation is not accepted here. Ligation, clipping, yeah, can damage the nerve. Of course, electricity doesn't use for the brain forever. Forget about it. You will destroy the brain. No any diathermical coagulation. So that method is used. I think I give for you satisfied methods of arresting of bleeding permanently inside of the wound. Now we come to the last method. Permanent arresting of the bleeding outside of the wound. This method, guys, we call ligation in distance. Now, imagine this laptop, it is the place of the bleeding. Because of several reasons, I cannot work here. Generally, I can mention 3 reasons. Reason number 1, huge amount of the bleeded vessels. If I will try to clip each one, I will lose the time and life of the patient. Situation number 2, inflamed wound. Inside of inflamed wound, guys, vascular wall stand very soft, like the butter. If you will apply the ligature into the butter and will try to tie it, it will cut the butter and cut also. Situation number 3, burning wounds. Now, I don't know, do you see it or no, but it has one specificity. It gives the surface bleeding, not pointer bleeding. Sorry if no point into which structure I will apply the forceps. I see bleeding from all surface, not from point. Do you understand it or not? They say, what can I do? I must know which artery come to this region and supply it. And I must open this artery outside of the wound. That's why this method we call ligation in distance, distance from the wound. How I can do it? According to 2 informations. Information number 1, projection. Information number 2, layer of adhesion. We need usually in 3rd information. It is syncope of the structures if it is not a lone vessel, but if it is neurovascular vessel. I must understand, for example, I know her direction, but I don't know what is located in front. If I will go directly along of this projectional line, of course I will damage the structure which is immediately in front. Maybe in that case I will do the approach from side, I don't know, from medial, from lateral, sometimes from back. Yeah, from back. For example, you can achieve the branches of facial nerve, not only from skin, but from mucous membrane of the internal surface of the cheeks, to not damage some structures which is in front of them. Let's say 3 informations I need again: projection, layer of vacation, and the syntropy of the elements, if it is not pass along. Okay, now I open this vessel. What after? After I take the instrument which we study, ligature needle, all another manipulations I show for you. Do you have two pens? Two, not one, two. Put it together. Give me. For example, this is two vessels. I told for you that strongly tip of the desha goes from the side of non-damaged vessel to the side of the damaged one. Not vice versa, to not perforate it intact vessel. All another rules is same, what I tell you before. In the proximal end, you apply two ligatures. In the distal end, you apply one ligature. By the way, distance between proximal last ligature and distal first ligature is 1 centimeter. Here distance is 0.5. Here distance is 1. Do you understand me or no? But we come now to important point. After ligation, I should take the scalpel and I should cut this artery between distal and between proximal ligatures, approximately here. I don't see confusing your face, and it is not so good. You must be confused now. You must say, but sir, why? Then we apply ligature, we arresting bleeding. Why we need now to cut the vessel between these ligatures? For what? What we will achieve by this?
Because we terminate the process from the both sides, then we can.
Why it is necessary?
So sorry, immediately we had the bleeding. So once we stop.
No, we don't have bleeding. Bleeding we have in the region of the laptop. Arteries goes to the laptop region. I open this artery before laptop and I apply 3 ligatures. First is loose, second and third is strong, as you understand. God's no. Of course, then I apply these 3 ligatures. I stop the blood flow from this vessel to the laptop. I arrest the bleeding in the region of the laptop. I think it is very understandable, but God's know why. After this ligation, I should take the scalpel and I should cut the wall of the artery. Or
Because anyway it will necrose, so if you cut it, it will not.
let's be necros. If this necros will be happen simultaneously, finally we will have the same picture.
But angiogenesis should form.
But what?
Angiogenesis, like new formation of new blood vessels.
But what is connection between formation of the new vessel and cutting of the wall of the vessel? Why you think that if I will cut the vascular wall, I will stimulate it, the angiogenesis?
Normally when the necrosis is formed, the cells won't be repaired immediately.
First of all, it is unique necros, which we call aseptical necros. It doesn't give any putrefaction and formation of the purulent process. This kind of aseptical necros now in your body is happening in 100 different places. For example, you lose epithelium of your intestine every day. You lose samely epithelium of your respiratory system every day. What is it? It is necros. To form the new structure, you must kill the old one. That is normal process. Say, he doesn't disturb me anyhow. But what the matter? Why I cut the wall? You see. Everything is simple, friends. Because we know that inside of the vascular wall, in adventitia, we have the sympathetical nerves. If I just ligated the vessel, of course I irritated the sympathicus. If I irritated sympathicus, it gives the vasospasm of all neighboring vessels. I close not only the main pathway of supplyment, but the collaterals also. Then you cut the wall of the vessel, you make desympathization. Impulsation will not go to the sympathicus, collaterals will be enlarged. You know, vessels doesn't have parasympathetical innervation. Sympathicus is work. If it is activated, we have vasospasm. If it is deactivated, we have the dilatation. Method is called desympathization. Remember, please, the famous German surgeon Opel firstly describe this method. Opel saying something else. Opel saying if you ligated the artery which is supplied some region, try to ligate on the vein which is drained this region also. You understand what I told you? I ligated the artery which is come to you. Of course I decrease your supply. I will do my best for primary time, first days, to decrease also the blood outflow from you. Because if the more blood will go, less blood will come, we will have the hypoxia up to necrosis. If I decrease the arterial flow, I should decrease venous one also to have equilibrium. You understand me? Usually it's not hard, because usually vessels pass together. They form neurovascular bundles, as in front of an occipital, temporal regions, which we described together. It can be, for example, one artery, two veins. In that case, you will ligate it one vein. It can be one artery, one vein. In that case, you will ligate it just one vein. It is understandable. You can say, but what will be happen without? Don't worry. Except this big vein, there are small other veins. They will provide it the drainage anyhow. Do you understand it? That's it. We completely finished to speak about bleeding only from soft tissues. Now let's come to the bleeding from the bones. As you know, as I tell you, inside the diploidic layer of the bones, we have the diploidic veins. And if there are the fracture of the bone, of course it can give the trauma of these veins. Bleeding is not so profuse, because inside of these veins we don't have so high pressure. Only one exception, if it is region of the main emissary veins. In that case, of course you know that there are communication, between three venous systems. We can have profuse bleeding from the diploidic layer due to the anastomosic with all another veins which we have in this region. Anyhow, how we make arresting of the bleeding? Point number one, immediately we ligated the emissary vein if it is involved in the traumatization. It should be ligated for two purposes. Purpose number one, to decrease the bleeding. Purpose number two is much more important, to prevent passage of infections. If it's happened, that is one case, but you will do your best to prevent its formation. Very well. You ligated the emissary vein. What after? After this, you start to arrest the bleeding. Nowadays, we have two main methods. Method number one, it is the sterile wax. It is beeswax, specially prepared. Sterile, which has the gluing effect. You put it in your finger or in spatula. You apply it in the bleeding region of the bone. It makes the adhesion with the bone. It is gluing with these small pockets which we have inside of the diploidic layer, and it is stop the bleeding. Why? Because pressure is not high, as I said before. Method number two is more pragmatical method. Hold your hands like this. Imagine that this is two compact layers, external and internal, and you have marginal bleeding from diploidic layer. It means there are the fracture. Second method is more dramatical. You apply the Dahlgren forceps and you press the compact layers to each other. Then you press the compact layers. Due to the spongy qualities of the diploidic layer, they connect to each other and they press the sponge. Sometimes then you, I don't know, do you eat the meat or not, but if you will eat, for example, chicken, you can try to press the bones by your fingers, by your teeth, and you will see that they will be depressed. Compact layers will be connected to each other, sponge will be closed between them, and we will achieve our goal. We will arrest the bleedings. So remember, please, from the bones, there are distant, because I cannot ligate it, the bone. I cannot apply the arterial forceps on the bone. I cannot even coagulate it bone. That is impossible. So this is the methods which we use. Very well. Can you change the slide? No. Go. One more. No. Next one. No. Next one. Thank you very much. We finished to speak about bleeding from soft tissues. We described the bleeding from the bones. Now let's come to the bleeding from dura mater venous sinuses. One of the most dangerous bleedings from head region because of two causes. Cause number one, huge diameter of the structure, especially superior sagittal sinus, transverse sinus, sigmoid sinus, sinuses which is in base of skull, like petrosus sinuses, occipital sinus, that is not so big. But the mentioned sinuses, sinus cavernosus, sigmoid, huge. Second point, why it is so profuse bleeding, no muscles in the wall of these vessels. They have two layers. It is dura mater and intima, which is covered from inside. If no muscles, no constriction. What is the first physiological mechanism then the vessel is damaged? Vasoconstriction. Vasoconstriction decrease the bleeding and make possible, survival of the patient. Here vasoconstriction will be absent. That's why we must be very careful in case of these bleedings. There are four main methods of the treatment of these bleedings. Method number one. As you can see in the picture, if it is line-shaped form of the defect, what does it mean line shape? No any loose tissue between the margins. You can apply just the sutures. By the suturing of it, you can close. Usually it is very, very slim thread, 7-0 and more. Usually it is cutting needle because it's very dense and it will be hard to penetrate it by the piercing one. And usually it is interrupted form of the suture. Distance between two sutures, it is less than half of the millimeter, very near to each other. This is method number one. Again, I say you, if it is line-shaped form of the trauma, you can make the suturing and you can make recanalization of the sinus. Situation number two, if there are whole, otherwise loose tissue, minus tissue. Stupid person, again, will take the needle and will try to close it. And of course it will give the obstruction of the wall of the lumen of the sinus due to two reasons. Reason number one, then you close the defect. You connect it far margins from each other. It is mechanically decrease the size. Reason number two, I say 2 minutes before, no elasticity, friends. We don't have here muscle. So you understand that it's impossible to tense the margins without closing of the loop. So what can I do? Plastical reconstruction. Usually, of course, it is autografting plastical method. From the same patient, you take the grafting material. Who can give me just one paper, one page from your exercise book? I must show, I forget to take my own. Just one, not 100, one. It's enough, it's enough, it's enough. Thank you very much. Can I take your pen? Okay. Now let's modulate this situation. I will show. First I will modulate it, then I will show. That is our sinus. This sinus is damaged. For example, bullet trauma, knife, by the way, if it is very strong trauma by sharp body, it can perforate the bones. It can perforate the sinus wall. Especially mainly it is superior sagittal sinus or transverse sinus because that is the most superficial sinuses of our head. Now let's make the hole on the wall of this sinus, something like this. Okay, there are something like that. Aperture in the wall of the sinus. If I will try to suture it, as I say you, I will decrease the lumen. If you will decrease the lumen, intracranial pressure will be increased. If it will be increased, the person will be dead. I told you, yeah, if it is critically increased, yeah, not just headache, but high increasement of the pressure, cerebellum inclinated into foramen occipital spire, it is pressed the medulla oblongata, it is killed the person. By cerebellum, because it is more movable part of it. What can I do? I must remember that especially in the fornix region, dura, which has two layers, these two layers doesn't fuse to each other, and we can separate them. By the way, in the base situation, another layers is fused to each other, and separation is impossible. Okay, anyhow, near the wall of this aperture, from superficial layer of dura mater, by the diameter which approximately in half of centimeter more than diameter of defect, we form the flap. Thank you very much. 1 minute wait. Sorry. Base of the flap look to the side of this aperture. Something like this. This is method which is firstly described by famous Russian surgeon Burdenko during the Second World War. And it is saved huge amount of the lives. Now what after? I turn it into the defect side, and I don't forget to apply the sutures. By the way, sutures should be applied also in the region of the base. Now you can take it. Thank you. Something like that. Because if I will not suture this base region, blood will flow between two layers and come towards it. You can say me, how the person can live by one layer of dura? Simply can live, no any problem. Method is great, method is useful. Look, flap, which is close the defect. But unfortunately, method has one problem. It can be used only for not so much big defects. Otherwise, from neighboring dura, you will not be responsible to form the big flap. Usually 3 centimeters, 3 inches, not more. You can say me what to do if it is more. Usually in the neurosurgical department of our hospitals, we have specially conservated cadavers, dura mater. This is so-called heterogeneous grafting material, but we need to specially treat it. Usually we impregnated it by metallic ions to prevent autoimmunity reactions. From outer methods, also we can take one layer of Galea aponeurotica, because histologically it is same fibrous tissue and it gives the good regeneration. Sometimes even some authors suggest to take the piece of the muscular structures, for example, part of the front occipital muscle. Method is not good because you suture different structures and usually it doesn't give the strong regeneration. But all previously mentioned methods can be used. Please.
Can you explain the first method once more?
First, what do you mean first?
Material.
Plastical closure. Now look, this is the